Welcome to the deep dive. Today, we're getting into something that seems, well, quite simple on the surface, how bones grow, specifically a child's wrist. But, for something so fundamental, it's actually quite surprising there's been this real lack of clear age-specific guidelines for what's normal. So our mission today is to explore some really groundbreaking research that's managed to map out normal wrist development in children. Think of it as a vital compass for doctors and surgeons. It's really a shortcut to getting properly informed on a critical orthopedic topic, because understanding what's normal, well, that's always the first step, isn't it? It's absolutely key for spotting problems early and treating them effectively, especially when you think about common things like fractures in kids or perhaps more complex congenital conditions. And we're incredibly fortunate today. We have one of the leading minds behind this pivotal research right here with us. He's a true pioneer in this area of orthopedic surgery. A very warm welcome to Professor Moy Imam, Prof. Moy Imam. Thank you. It's a real pleasure to be here and talk about this work. Great. Okay, let's dive right in then.
Professor, perhaps you could start by explaining why understanding this normal development pathway in children's wrists is just so important for clinicians. It sounds basic, but clearly it wasn't straightforward. Prof. Moy Imam, it's fundamentally important. And the numbers, actually, they really highlight why. Wrist fractures, we're talking specifically about the distal radius, that's the big forearm bone near the wrist, and the carpal bones, the small ones in the wrist itself, they're incredibly common in children. Prof. Moy Imam, they account for roughly about a quarter of all fractures in pediatrics. And what's also quite concerning is that the incidence, the rate of these injuries seems to be on the rise. So it's a growing public health issue. A quarter, that's a huge proportion, Prof. Moy Imam. It is. And it's not just injuries, not just trauma. We also deal quite frequently with various other conditions, congenital malformations, for example, that can significantly impair the natural growth and development of those forearm bones, the radius and ulna, and the carpal bones, too, right through childhood and adolescence, Prof. Moy Imam. So without having a really precise age-specific picture of what normal actually looks like at each stage, managing these conditions becomes, well, incredibly complex, often relying more on, shall we say, educated guesswork than hard data. Right? So it's a high volume of cases covering everything from playground falls to perhaps more complex developmental issues. And you mentioned this knowledge gap. Can you unpack that a bit? What exactly was missing historically? Why was it so hard to get this data for kids?
Prof. Moy Imam.
Exactly. The core challenge historically was that the medical literature just lacked standardized measurements. There weren't precise radiological indices specifically designed for children's wrists, Prof. Moy Imam. This meant clinicians, well, they often had little choice but to fall back on adult reference values. And that's obviously problematic because adult bones are fully formed, presumably, Prof. Moy Imam.
Precisely. Those previously known adult values for these anatomical parameters, they're often quite far from accurate when you apply them to a growing child.
And the main reason for that is because getting accurate, reliable measurements is inherently difficult in very young children. Prof. Moy Imam, it's down to the developing ossification centers. These are the parts of the bone that are still cartilage, still hardening into bone. They just aren't consistently visible or fully formed on a standard X-ray in the same way they are in adults.
I see. So you're trying to measure something that isn't fully there yet on the image. Prof. Moy Imam. In essence, yes. It's like trying to restore a painting without the original blueprint. You're making your best estimate. And that's where this research really comes in, Prof. Moy Imam. What's fascinating here, and what we really wanted to address, is that without that clear template of normal growth stage by stage, it's genuinely like navigating in the dark for orthopedic pediatric surgeons, for hand surgeons, Prof. Moy Imam. It becomes incredibly challenging to confidently differentiate between what's just normal physiological growth variation and what's an actual pathological deviation that needs treatment. This research provides that much-needed map, effectively. It shines a light.
That's a powerful analogy, navigating in the dark. It really highlights the clinical need. So, faced with this gap, what were the specific goals? What did this extensive research actually set out to achieve? Prof. Moy Imam. Well, given that critical need, we designed the study with two very clear interlinked goals. The first was to identify, carefully considering the natural ossification pattern, precisely when it becomes valid and reliable to measure 10 specific radiographic parameters of a growing wrist. Prof. Moy Imam. Using a reliable standardized method, of course, this directly tackles that issue of the varying ossification stages we just talked about, essentially pinning down at what age you can actually see and measure each feature accurately and consistently on a standard X-ray. Finding the window of measurability, if you like, right? So step one is figuring out when you can actually measure things reliably. Prof. Moy Imam, exactly. And then secondly, and just as importantly, we aim to establish yearly based normal reference values for these 10 measurements for both boys and girls right across that developmental span from age 1 to 16. Prof. Moy Imam. The idea was to provide an indispensable evidence-based guide for all clinicians involved in treating children with wrist problems, be it fractures or other pathologies. Prof. Moore Imam. If you connect this to the bigger picture, I mean, these goals are fundamental. They empower clinicians to make much more informed, much more precise decisions, whether that's planning the best way to fix a fracture or diagnosing a subtle developmental issue accurately. It shifts us away from guesswork, often based on adult norms, towards precise, age-specific, evidence-based pediatric care. That sounds incredibly thorough. And you mentioned it was extensive research. This wasn't just looking at a few x-rays, was it? Can you give us a sense of the scale and the methodological rigor involved? Because that's what gives the findings their weight, isn't it, Prof. Moore Imam?
Absolutely. The scale was, it was significant. And the methodology had to be meticulous to ensure the findings were robust. We conducted what's called a retrospective multi-center analysis. Prof. Moore Imam. That means we gathered data from several different hospitals or clinical centers.
This automatically helps make the findings more generalizable, more applicable across different settings. So not just one hospital's patient group. Prof. Moore Imam.
Correct. The study analyzed radiographs x-rays from 896 children. Specifically, we looked at 896 posterior anterior views, that's the front to back view, and 896 lateral or side views. Crucially, all these children had normal, healthy wrists. Prof. Moore Imam. And this data wasn't collected over a short period. It spanned 2 full decades, from January 1996 right up until April 2016. That long time frame was quite deliberate. It allowed us to capture a really wide and representative range of developmental stages and natural variations over time. 2 decades worth of data, that's quite something. And how did you group the children? Prof. Moore Imam, to make sure we had a good understanding across the whole growth period, the children were meticulously stratified into 16 distinct yearly age groups. So from age 1, age 2, all the way up to age 16, Prof. Moore Imam. And within each S group, they were further divided by sex. We had 471 males and 425 females, so a pretty even split. And importantly, each single age group included a minimum of 50 children, 50 per group.
Why that number specifically? Prof. Moore Imam. That minimum number wasn't arbitrary. It came from a power analysis we did before even starting the main data collection. It ensured we had enough statistical power within each age bracket to detect differences that were not just statistically significant, but also clinically meaningful. That makes sense. And I imagine defining normal for inclusion must have been incredibly strict for a study like this. How did you ensure you were really looking at healthy wrists? Prof. Moore Imam. Oh, absolutely rigorous. We had a very strict inclusion and exclusion process. Firstly, only x-rays that had been officially reported as normal by a specialist radiologist were even considered. Prof. Moore Imam. But we didn't stop there. These normal images then underwent a second, independent check by 2 experienced orthopedic investigators, myself included. This 2-stage process meant we could systematically filter out any images showing obvious fractures, of course, but also any subtle abnormalities or even minor technical errors in how the x-ray was taken that could affect measurements. So double-checking everything, Prof. Moore Imam. And we also excluded children if they had any relevant medical history, things like congenital problems, systemic diseases that affect growth, or even previous fractures in that wrist. Anything that could potentially skew the growth pattern away from normal. Prof. Moore Imam. This focus on normal is just so critical. You simply can't define what's abnormal without a crystal clear, robust baseline of what normal development looks like at every single age. Prof. Moore Imam. The sheer number of children involved, combined with this very careful selection and double validation process, gave us that highly robust baseline. It really is the foundation upon which all the subsequent findings are built. Getting that right was paramount. I can tell you, sifting through thousands upon thousands of images, cross-referencing clinical histories, it was a huge undertaking, but absolutely necessary. That level of scrutiny is really impressive. It certainly builds confidence in the baseline. So, once you had this vast, carefully curated data set of normal wrists, what were the specific things you were measuring? These 10 key radiographic parameters. Could you walk us through them? What does each one tell you?
Prof. Moore Imam.
These 10 parameters, when taken together, they give us a very comprehensive geometric profile of the developing wrist. We measured them meticulously, but always dependent on the wrist's ossification pattern, meaning only when that specific feature was clearly visible and reliably measurable on the x-ray for that age group. Prof. Moore Imam. Okay, so first we looked at ulnar variance. This measures the difference in length between the 2 forearm bones, the radius and ulna, right at the wrist joint. It's measured as the perpendicular distance between their end lines, essentially telling us if the ulna is shorter, longer, or the same length as the radius at that point. Important for load distribution,
Right.
how they line up.
Prof. Moore Imam, exactly. Then radial height. This is the height of the radius bone at the wrist end, measured from its main shaft line up to the tip of the radial styloid, the bony prominence on the thumb side. It relates to the overall space available for the carpal bones. Prof. Mo Imam. Next is radial inclination. This is an angle. It measures the sideways tilt of the end surface of the radio. Think of it like the slope on the end of the radius where the wrist bones sit.
It's crucial for how the wrist moves side to side, like a ramp. Prof. More Imam. Sort of, yes. Then the radiocarpal angle. Another angle, this one assesses the overall alignment of that first row of carpal bones relative to the radius. It gives an indication of how well the hand is seated on the forearm. Prof. Mo Imam. Moving to the carpal bones themselves, we measured carpal height. This is the overall height of that block of small carpal bones measured along the line of the third metacarpal, the long bone in the hand leading to the middle finger. It tells us about the compactness or potential collapse of the carpus, Prof. More Imam. And related to that is the carpal ratio. This simply compares the carpal height to the length of that third metacarpal. It gives us a proportional measure, which is useful because it adjusts for the child's overall hand size. Okay, so those are mostly from the front on view. Prof. More Imam, those first 6, yes, are primarily from the PA view. Then on the lateral, the side view, we assessed volar tilt, sometimes called palmar tilt. This measures the forward tilt of the end surface of the radius, so how much it slopes towards the palm side. Very important for wrist flexion and stability. Prof. Mo Imam. Then we looked at the relationship between 2 key carpal bones, the scaphoid and the lunate. The scapholunate angle measures the angle between the axes of these 2 bones. Changes here can indicate instability. Prof. Mo Imam. Similarly, the capital-lunate angle measures the angle between the lunate and the capitate, which is the large central carpal bone. Again, it's assessing the alignment within the carpus itself, Prof. Mo Imam. And finally, the scapholunate distance. This is simply the gap measured between the scaphoid and the lunate. In adults, a widening of this gap is a classic sign of a ligament tear. Prof. Mo Imam. So you see, each parameter gives us a unique piece of the developmental puzzle alignment, proportion, angles. Together, they build that comprehensive geometric profile we needed, vital for understanding both normal growth and spotting subtle problems. That is incredibly detailed. 10 different measurements across multiple centers over 20 years. Which brings me to the question of consistency. How could you be absolutely sure that these measurements were accurate and reliable? How did you ensure that precision? Prof. Mo Imam. A critical question indeed. And ensuring reliability was a major focus. All the radiographs, regardless of when or where they were taken over that 2-decade span, were rigorously checked for quality and adequacy. This was done first by a senior radiologist and then independently by the 2 orthopedic investigators involved, Prof. More Imam. We adhered to a very strict preferred imaging protocol. This meant consistent patient positioning was paramount. For example, the patient always had to be seated, forearm resting flat, specific hand and finger positioning for both the PA and lateral views. This standardization was absolutely key to minimizing variability right from the start. So the way the x-ray was taken was standardized as much as possible. Prof. Mo Imam, exactly. But beyond that, we rigorously tested the reliability of the measurements themselves. We calculated what are known as interclass correlation coefficients, or ICCs. These statistical measures assess agreement. Prof. Mo Imam, and our study demonstrated excellent reliability with ICCs consistently above 0.85 for all 10 parameters. This covered both intra-observer reliability, meaning the same person measuring the same X-ray at different times got consistent results, and inter-observer reliability, meaning different people measuring the same X-ray also got consistent results. Above 0.85, that sounds very high. Prof. Mo Imam. It is considered excellent in this context. This high level of consistency is absolutely vital for clinical usefulness. It means the reference values we've established are trustworthy. Clinicians in different hospitals using these guidelines can be confident they will arrive at similar, reliable conclusions when assessing a child's wrist. It provides a shared, objective standard that really does solidify the findings. Knowing the measurements are so reproducible gives immense confidence. Okay, so Professor, we have the what and the how. Now for the really fascinating part, the what did you find? Yeah. What did this incredibly detailed data actually reveal about the dynamic journey of a child's wrist as it grows and matures? Prof. Mo Imam. Right, this is where the developmental picture really comes alive. We found very clear age milestones for when different parameters actually become reliably measurable on these standard X-rays. Prof. Mo Imam. For instance, 4 key measurements, ulnar variance, radial height, carpal height, and the carpal ratio. These were all consistently definable and measurable right from the first year of life. That's quite significant because it means clinicians can start assessing these fundamental relationships very early on using objective data. So even in a 1-year-old, you can reliably measure those 4 things. Prof. Mo Imam. Yes, with the standardized methods we used. Then, as children get a bit older, more features become clear enough to measure accurately. From around age 4, radial inclination, the radiocarpal angle, and the capital lunate angle became reliably measurable. Prof. Mo Imam. This timing makes sense biologically because their accurate assessment really depends on the epiphysis, the end part of the bone being sufficiently calcified, hardened into bone to show up clearly on the X-ray. Before age 4, these areas are mostly cartilage, still developing essentially, Prof. Mo Imam, precisely. Then, a bit later, from age 6 onwards, we found that the scapholunate angle and the scapholunate distance could only be reliably measured. This timing correlates directly with when the ossific centers of the lunate and scaphoid bones themselves typically appear as visible bone, usually around ages 4 and 5 respectively. So you need both bones to be sufficiently ossified to measure the relationship between them accurately. Okay, so different timings for different measurements based on when the bones actually develop enough to be seen clearly. Prof. Mo Imam, exactly. And one final example, the palmar tilt or volar tilt measured on the side view. We found this wasn't really developed or consistently measurable until about age 11. After that point, it started to gradually increase. This relies on the development of the distal radius's volar inclination, which typically occurs around age 10, Prof. Mo Imam. So it really underscores the dynamic nature of growth. You can't just apply one standard measurement technique across all ages. Our findings pin down precisely when these different parts of the wrist become sufficiently ossified and geometrically stable enough for accurate radiographic assessment. That's such a crucial point. It's not just what you measure, but when you can measure it reliably. Beyond that timing, what were the most striking growth trends or patterns you observed? How did these parameters change as children got older? Any surprises?
Prof. Mo Imam. Yes, several really interesting and clinically important patterns emerged. Let's take ulnar variance again. We confirmed a clear predominance of what we call ulna minus variance in children throughout most of their growth, meaning the ulna is shorter than the radius at the wrist. Prof. Mo Imam, correct, on average. And what was fascinating was that this characteristic remained remarkably stable. It didn't consistently change from birth right up until about age 14, but then quite abruptly, it showed a rapid increase around ages 15 or 16. It typically moved towards a neutral variance, or sometimes even a positive variance, where the ulna becomes longer than the radius as the child nears skeletal maturity. That's a really distinct shift. Does that have clinical implications? Prof. Mo Imam, we think it does. This predominant ulna minus variance during childhood could, hypothetically, be a natural protective feature.
It might help explain why certain conditions common in adults, like injuries to the TFCC, that's the triangular fibrocartilage complex, a key stabilizer or ulnar impaction syndrome, are relatively rare in children. The anatomy itself might be protective during those years. Interesting. What about the other measurements? A Prof. Mo Imam. Well, radial height, radial inclination, and the radiocarpal angle all showed a very consistent pattern, a steady, predictable increase throughout the growth period. They generally reach their adult values right around the onset of the pubertal growth spurt. This clearly reflects the gradual expansion and specific shaping of the end of the radius bone as it matures. Prof. Mo Imam. For carpal height, as you'd expect, it showed a constant increase with growth, reflecting the lengthening of the carpal bones. But the carpal ratio comparing carpal height to the third metacarpal length showed no obvious increasing or decreasing trend. This suggests the proportions within the wrist and hand remain remarkably consistent relative to each other throughout growth, even as the absolute size increases. So the overall shape stays proportional. Prof. Mo Imam seems so, yes. Now, a particularly important finding, especially for avoiding misdiagnosis, relates to the scaphoid and lunate. We observed a significantly wider scapholunate distance in younger children, and this gap gradually narrowed as they grew older. Prof. Mo Imam. Similarly, the scapholunate and capitolunate angles were found to be larger in children compared to adults, and they showed a downward trend, becoming smaller as growth progressed, generally stabilizing around 12 to 13 years of age. Why is this so important? Prof. Mo Imam. Because in adults, a wide gap or abnormal angles here are signs of instability, often requiring surgery. But in children, our data shows this is just a normal part of development. As those carpal bones ossify, changing from cartilage to solid bone, the space between them naturally tightens and the angles change. It's crucial not to misinterpret this normal developmental phase as pathology. Prof. Mo Imam. And finally, the palmar radial tilt, once it became measurable around age 11, it increased gradually, reaching adult values by the time puberty finished, finalizing the wrist's adult configuration. Prof. Mo Imam. So if you put it all together, these predictable, reproducible, anatomical changes map out a clear developmental pathway. They establish that vital baseline needed to distinguish normal variation from true pathology at different ages. The consistency we found really strengthens the clinical utility. That is incredibly clear. The pattern seems so distinct. Now, one thing that often comes up in development is differences between sexes. One might naturally assume boys and girls' bones might grow differently, maybe at different rates or reaching different final configurations. Did your research find significant sex differences in these risk parameters? Prof. Mo Imam. That's a very common assumption, and it's one of the areas where our findings were particularly significant and perhaps, yes, a little surprising for clinical practice. Prof. Mo Imam. Despite analyzing data for 471 boys and 425 girls across 16 age groups, our extensive analysis revealed no significant sex differences across any of the 10 measured radiographic parameters. None at all. It's quite definitive. Prof. Moimam. It was a very clear and consistent finding. When we performed the statistical analysis, age was the only significant predictor for the changes we observed in these measurements. Neither the child's sex, nor even their hand dominance, whether they were right or left-handed, were found to be significant factors influencing these specific risk parameters. That's really fascinating and incredibly practical for clinicians, I imagine. It simplifies things considerably. Prof. Mo Imam. It does indeed. It means one less variable to factor in when assessing a child's risk radiograph against these norms. Before this research, without this definitive pediatric data, there might have been perhaps a subtle bias or an underlying assumption that growth patterns would differ between boys and girls, leading to maybe uncertainty in diagnosis. Prof. Mo Imam? Potentially, yes. A clinician might have seen similar measurements in a boy and girl of the same age and wondered if it meant something different for each, perhaps leading to unnecessary follow-up, extra imaging, or maybe even just diagnostic uncertainty. Prof. Mo Imam. Our finding that, for these specific risk measurements, there are no significant sex differences provides a single unified age-specific reference range. It streamlines the assessment. Clinicians don't need separate charts for boys and girls for these parameters. They can confidently apply the same age-matched normal values regardless of the child's sex. That removes a layer of complexity then, Prof. Moimam. Exactly. It allows the focus to be purely on the objective measurements compared against the established norm for that child's chronological and skeletal age. It's a powerful message of biological uniformity in the specific anatomical context, at least concerning these widely used radiographic parameters. That clarity is so valuable. Okay, so Professor, let's bring all these threads together. We have the precise measurements, the clear age-related changes, the lack of sex differences, the rigorous methodology. What does this all mean in practice? How did these detailed findings directly benefit the orthopedic professionals on the ground and ultimately the children they're treating? What's the real so what here? Prof. Moimam. Right? The clinical application is the ultimate goal. Essentially, the study's findings collectively provide a unique and frankly long overdue template of pediatric normal values. This acts as an invaluable practical guide for ham surgeons, pediatric orthopedic surgeons, even radiologists and pediatricians when they're managing children with wrist problems. Prof. Mo Imam. The core benefit is the ability to compare a child's specific risk measurements against these robust age-specific normal values. This allows for much earlier and more precise identification of any deviations from the expected normal growth pattern. So, better diagnosis, essentially. Prof. Mo Imam. A better and earlier diagnosis, yes, but it goes beyond that. This evidence is also crucial for guiding treatment, particularly after trauma. For instance, when reducing a distal radius fracture, these values provide objective targets to aim for, helping ensure the fracture heals in the best possible anatomical position for long-term function and minimizing the risk of later problems like stiffness or arthritis. Before, judging the adequacy of reduction was often more subjective. That makes sense. Can you give some specific examples of how these values help differentiate normal from abnormal or act as predictive tools? Prof. Mo Imam, certainly. Let's look at ulnar variance again. The reference values we establish are now critical for distinguishing truly impaired ulnar growth, which you might see in conditions like juvenile arthritis or certain genetic conditions like hereditary multiple exostoses from an ulnar variance that, while maybe appearing short or long, still falls within the normal developmental range for that specific age. It prevents overdiagnosis of pathology. Prof. Mo Imam. Furthermore, tracking ulnar variance over time using these norms can become a useful prognostic tool. For children with known progressive bone or joint diseases, monitoring this value can help identify those at higher risk for developing secondary problems like instability or subluxation of the carpus, allowing for earlier intervention if needed. So it helps monitor ongoing conditions too. Prof. Mo Imam. Absolutely. Then consider carpal height. Our study reinforces its value not just for diagnosis, but also for assessing disease severity and tracking the progression of what's termed carpal collapse. For example, we know that reduced carpal height can be seen in conditions like multiple epiphyseal dysplasia or Turner syndrome. Conversely, an increased carpal height can be a feature of achondroplasia. Prof Mo Imam, and perhaps even more powerfully, subtle early changes in carpal height can actually predict poorer long-term outcomes in children with juvenile idiopathic arthritis. That's invaluable information for managing treatment and counseling families. That's a very direct link to predicting outcomes. Prof Mo Imam. It is. And similarly for radial height and inclination, we confirmed that loss of radial height or significant changes in radial inclination after a fracture are strong predictors of a less favorable outcome, both in children and adults. Knowing this helps guide how aggressively we might need to intervene to restore the anatomy after certain types of distal radius fractures. Prof Mo Imam. Radiocarpal angle also proved useful. It aids in diagnosing certain congenital anomalies like the characteristic hand shape seen in Hurler syndrome, and it's instrumental when we're treating growth plate injuries, physial arrests, to assess if we've restored the normal alignment. Prof Mo Imam. So taken together, these findings really allow clinicians to be more proactive. We can anticipate potential issues, intervene more precisely, monitor progress objectively, all guided by these evidence-based measurements. It leads to better, more tailored care. That's a clear shift towards more precise, proactive care. What about those very young children, though, where the bones, as you said, aren't fully ossified and might be hard to see clearly on an X-ray? How does this research help navigate that challenge and avoid misdiagnosis? Prof Mo Imam. That's a profoundly important application because managing injuries in very young children, say under 4 or 5, presents unique challenges precisely because of that incomplete ossification. Prof Mo Imam. In situations where the distal radius epiphysis isn't yet fully visible on the X-ray, the combined measurements of the parameters we can see reliably from age 1, ulnar variance, radial height, and carpal height become the only reliable objective guide for assessing the reduction and monitoring the healing of distal radius fractures. So you use the relationships you can measure to infer the position of the parts you can't see clearly. Prof Mo Imam. Essentially, yes. These established normal values for the measurable parameters give us the necessary reference points. They provide objective data to guide treatment even when the key bone ends are still largely invisible cartilage. It allows for accurate management where previously it was much more difficult. Prof Mo Imam. And linked to avoiding misdiagnosis, I must reemphasize the point about the scapholunate relationship. It is absolutely crucial that clinicians understand the naturally wider scapholunate distance and the larger scapholunate and capolunate angles seen in children are normal developmental features. Prof Mo Imam. They should absolutely not be mistaken for carpal instability, which is a significant adult pathology often requiring surgery. Our study provides the biological explanation: the gap narrows and angles decrease naturally as the cartilage ossifies, so a child's X-ray might look alarming if judged by adult standards. Prof Mo Imam. Exactly. Without this knowledge, a child with perfectly normal developing wrists could easily be misdiagnosed with instability. This could lead to unnecessary anxiety, further investigations, maybe even inappropriate treatment for what is simply healthy growth. It really raises the question, how often might this have happened in the past? Our data helps prevent these critical misdiagnoses. That impact alone preventing misdiagnosis and unnecessary interventions is huge. Now, shifting gears slightly, for surgeons planning more complex procedures like correcting deformities, timing is everything. Does this research offer guidance on when it might be safest or most appropriate to perform procedures like corrective osteotomies? Prof Mo Imam. Yes, it does offer a very practical guideline for surgical planning. Our findings indicate that corrective osteotomies procedures where we cut and realign bone to correct a deformity can generally be safely performed from the age of 12 years onwards without jeopardizing the child's remaining normal wrist development. From age 12. Why that specific age? Prof Mo Imam. The reasoning comes directly from our data. We observe that most of the key radiologic parameters demonstrate only minimal changes from the 12-year-old time point through to skeletal maturity. This suggests that by age 12, the wrist has achieved a significant degree of anatomical stability and maturity. The major developmental changes have largely occurred. Prof Mo Imam. Performing the surgery after this point is less likely to interfere with unpredictable growth spurts or significantly alter the final outcome due to ongoing natural development. It provides a clear, evidence-based window for surgical planning, offering clinicians and, importantly, parents greater confidence about the timing of such interventions. It helps ensure we choose the optimal time for the best possible long-term result. That's incredibly helpful, providing that objective marker for surgical decision-making. Professor, as with any research, it's important to understand the context. Are there any nuances or limitations to this study that clinicians should bear in mind when applying these findings? Prof Mo Imam. That's a very fair point, and acknowledging limitations is always crucial in science. Firstly, while it was extensive, this was primarily a radiological analysis based on existing X-rays. Retrospective studies like this always carry an inherent, though hopefully small, risk of certain biases, perhaps in patient selection over the years, or potential underrepresentation of some very specific demographic groups. Prof. Mo Imam. However, we believe the study's rigorous design, the multi-center nature, the large sample size with at least 50 children per age group, spanning 2 decades, significantly mitigates these concerns and makes the data highly robust and broadly applicable. What about the lack of sex difference? Could there be very subtle differences the study missed? Prof. Mo Imam. It's possible. While we found no statistically significant sex differences, which is the key message for clinical practice, we do acknowledge that the study might theoretically have been underpowered to detect extremely subtle differences related to sex, or perhaps even handedness, if they exist at a very minor level. Our focus was on identifying clinically relevant significant trends and differences, which we did with high confidence. Prof. Mo Imam. Also, we did have to exclude a small percentage of radiographs due to technical errors or suboptimal positioning. This was necessary to maintain the quality of the data used for measurements. Given the huge overall number of images analyzed, it's highly unlikely this skewed the results, but it's a factor to note. And what about the fact that X-rays mainly show bone, not cartilage? Prof. Mo Imam. That's a fundamental point about the imaging modality itself. Plain radiographs primarily visualize ossified bone. They can't definitively tell us about the precise shape, position, or motion of the parts that are still cartilage, especially in very young children. So we can't say for certain if the angle and intervals we measured perfectly reflect the cartilaginous structure, or if they partly reflect asymmetries in how the bone itself is forming within that cartilage. Prof. Mo Imam. However, the study's core aim wasn't necessarily to map the cartilage, but to map the developmental array of the wrist as seen on standard clinical imaging to define what is consistently visible and reliably measurable using the most common tool, the plain radiograph. And that it achieved successfully. So while it's important to be transparent about these natural boundaries of the technique, the practical reliability and clinical utility of the developmental map we've created remain exceptionally high. That transparency is really helpful. And it does raise that question with advanced imaging like MRI available now, which shows cartilage well. Why focus a foundational study like this on plain X-rays? What's their enduring value here? Pro Mo Imam. That's an excellent practical question. MRI certainly offers incredibly detailed anatomical information, including cartilage, and it definitely has its place for specific diagnostic questions. However, plain radiographs remain the absolute cornerstone of musculoskeletal imaging for several very good reasons. Prof. Mo Imam. Firstly, they are simple, quick, and remarkably inexpensive compared to MRI. Secondly, they are highly feasible to perform on young children who might struggle to stay still for the length of time required for an MRI scan. Prof. Mo Imam. Thirdly, they provide an excellent immediate overview of the wrist's overall geometry, bony alignment, fracture patterns, and the stage of skeletal development. This makes them the most practical and accessible tool for broad clinical application, particularly in high-volume settings like A&E or busy outpatient clinics. For establishing these fundamental, widely applicable normal reference values across diverse healthcare systems, plain radiography was and remains the ideal tool. Prof. Mo Imam. So in essence, this research provides that precise age-stratified reference for normal wrist development using the most commonly available imaging. By doing so, it truly empowers clinicians, giving them the knowledge needed to provide superior, more confident care, leading to better outcomes for countless children with wrist injuries and conditions. It's about building a more evidence-based foundation for pediatric orthopedics. Professor Mo Imam, thank you so much. That was an incredibly insightful journey through the intricacies of the growing wrist. It's absolutely clear how this work reshapes understanding and provides such practical tools for clinicians. And for you, our listener, we've really taken a deep dive today, haven't we? Into how a child's wrist develops, why adult measurements just don't cut it, and how this groundbreaking research offers that essential map for doctors and surgeons. We've seen how understanding normal growth allows for early diagnosis, more precise treatment, and crucially helps avoid those misinterpretations of normal development as something pathological. If you found this deep dive valuable, please do take a moment to rate and share the show. It genuinely helps more professionals like you discover these crucial insights. And finally, as we reflect on the detailed age-specific changes within something like a child's wrist, it really makes you wonder, doesn't it? What other seemingly fundamental parts of our anatomy hold similarly complex developmental secrets just waiting to be unlocked to improve healthcare for everyone at every age?